I would like to present Professor William Small. He is a co-chair of the NRG Oncology Gynecologic Committee, and he is going to the ASTRO update contouring atlas in cervix and endometrial cancer. Professor Small.
Well, thank you again. I'm honored to be giving this talk. Sorry I can't be in Alexandria with you, but I'm very honored to be here, at least remotely. So what I'm going to talk about is an NRG RTOG consensus guidelines for the delineation of clinical target volumes for intensity modulated pelvic radiation therapy and postoperative treatment of endometrial and cervical cancer. It is an update of our previous atlas, and it has just been published in press, and the atlas is about to go online. So this, I think, is fairly timely to be talking about this. I'm honored to be here. So why isn't a contouring atlas important? I don't think I need to tell the radiation oncologists in the room why this is important. I think that when we teach our residents and our trainees, there's really two things that we do as oncologists. One is the oncology decisions. That's probably one of the more important things that we do, how we're going to treat patients. We're going to use surgery, chemotherapy, radiation, immunotherapy, a combination. But once we decide to give external beam radiation, our technology has gotten so good that we could target almost anything we want to, depending on how we treat, whether it's with IMRT or protons or other forms of fancy therapy. But if we don't contour the right areas, we either risk recurrence or we risk higher complications. So a contouring atlas, or at least knowing what we should be contouring, is incredibly important. The original atlas we did was in 2008. And this is the original atlas, which was published in the Red Journal. Again, it was the first attempt at our trying to do consensus guidelines for clinical target volume for postoperative cervical and endometrial cancer patients. And it really did shock me. For about 4 or 5 years, this was one of the more downloaded articles from the Red Journal, kind of showing that these things are needed and often very much quoted. When we started this, we formed this in 2004. For the original atlas, we had a consensus conference in 2005. A lot of us were transitioning at that point from 2D to 3D conformal radiation therapy and IMRT. It was specifically designed in preparation for RTOG 0418, which was a phase 2 trial of IMRT. It was really to see if we could do it. And I'll show some examples of how we were in the learning phase. And then shortly after that, there were 2 relatively big randomized trials, GOG 249, which, as you recall, was recently published in the JCO. It was a randomized trial of vag cuff and chemotherapy versus pelvic radiation in higher, so-called high-risk endometrial cancer, and GOG 258, which was a randomized trial between chemotherapy alone or chemotherapy and radiation for stage 3 or 4A endometrial cancer. And this contouring atlas was used in both of those randomized studies, and it was the first GOG trials that allowed IMRT. So I think the original contouring atlas, for good or bad, had a significant impact on some of our larger trials. What we used for the first atlas and what we used for both the first and the second atlas was anything we can get our hands on to try to define the target volume. Atlases of pelvic anatomy, pelvic imaging textbooks, surgical atlases, published IMRT, imaging studies, experience. We had radiologists involved, we had surgeons involved in both these atlases. And then for the second atlas, mostly through Dr. Patricia Eiffel's pushing, and she was right, we really did look at embryology too to try to define what targets we really need to treat, where things drain to, and what's important. This was just a table from the original atlas, and just to give you some background. Really what we did was we really were trying to reproduce what a lot of us had done for years when it came to basically 4 fields for the pelvis. We looked at the common iliacs. We talked about 7 millimeters before the L4-5 interspace. We talked about external iliacs, internal iliacs, upper vagina, perimetrium, and presacral nodes. Still kind of looking somewhat at some of the bony landmarks as a definition of what to do, because that's what we have done for for a long time, and it seemed to work fairly well. And this is some of the figures from the original atlas. Figure 1 shows the upper common iliac clinical target volume. This is the mid-common iliac and presacral. This is the lower common iliac and presacral target volumes, clinical target volumes. Upper external and internal iliac and presacrums, external and internal iliac clinical target volumes, and then down by the parametrium vagina, and lower in the vagina, parametrium, and lower in the vagina. I just kind of give you that for kind of historical what we did in the past, and we really did find some interesting things that we did good. We found some interesting things we could improve upon. So this is what we're really going to talk about. It's the updated consensus guidelines for the delineation of clinical target volume for IMRT in postoperative treatment of endometrial cervical cancer. I want to thank the speaker who will be following me, Jonathan Strauss. When I was at my previous institution, he was instrumental in helping getting this started. And then from my current institution, Matt Harkenrider and Courtney Hentz have been instrumental in getting this accomplished. So take a look back. How did the atlas work for RTOG 0418? Again, the first cooperative group trial trying to use IMRT in the postoperative treatment of cervical and endometrial cancer. It was interesting. This is what really told us that we really needed to do these kind of things and make sure we teach people. These are some of the actual contouring that we got on that trial. And this is with the patient being on trial with the investigator knowing we're going to review that with a contouring atlas that associated the trial and specific instructions. As you can see, this person's CTV simply included their vaginal marker with a small margin, which is obviously not the right target in the postoperative treatment of endometrial cancer. Again, another patient, similar target is inappropriate around the top of the vagina and then treating all the way to the vulva. People simply contouring the vessels, not the area around the vessels. The nodes don't lie in the vessel, they lie around the vessels. Not treating the external iliacs, treating a lot of bone and very big margins, treating too low. So again, I think that it was important to have that. We ended up changing volumes on a significant number of those patients when we first started doing IMRT as a group. So I'm glad we did the atlas, but I think education, things like this are incredibly important to make sure we're all on the same page. Again, this is the corrective proof. This is very topical because it just got published online in the Red Journal and will be published in press soon. So the background for this update is that we want to update the atlas that was constructed previously, again, we talked about. We also expanded what we did. We did periortic, common iliac, external iliac, internal iliac, presacral, and operator nodal regions, and a vaginal CTV was also defined. We did this by doing something different than we did for the first one. We did something a little scientific to begin with. We had 16 different experts in GI oncology, GI radiation, or gyne radiation oncology from around the world contour on a sample CAT scan, and then we looked at how good we were doing these contours. And this is a simultaneous truth and performance level estimation. It's kind of a busy slide, but I'll just say that we did okay. We all contoured about the same for common iliacs and external iliacs, moderately well for periortics and internal iliac and vaginal cuff, not too good for presacral and operator, where even as people that do this a lot, we weren't very consistent. Why do we add periortics? Because we wanted to make sure we had some contouring out there that's specific for gyne. And again, should you treat the periodic region, you should treat it if there's pathological or radiographic evidence of involvement, or if the clinician feels a risk of microscopic disease warrants treatment. I won't go into that controversy, but this volume encompasses the aorta, inferior vena cava, and the adjacent nodal regions with a non-uniform expansion off the vasculature. And I'll make some take-home points. I think it's important to contour on a non-contrast scan for the PA nodal CTV, as the inferior vena cava can distend with the administration of IV contrast and may lead to significant excessive contouring. So just briefly, the PA nodal CTV borders, at least as we defined them, superiorly for the cervical cancer at the level of the left renal vein for cervical cancer, and for endometrial cancer, we felt 1 to 1.5 centimeters above the left renal vessels. Of course, there's some exceptions to this. Obviously, if you have a high periodic node, you should probably go a little bit higher. And I encourage you to look at the manuscript for some additional recommendations. Inferiorly, the periodic nodal volume stops at the bifurcation of the aorta when it becomes the common iliac CTV. Anterior, we all thought 3 to 5 millimeters anterior to the IVC, up to 7 millimeters anterior to the aorta. The CTV delineation at the aortic space should be straight rather than concave. Posterior at the vertebral body, excluding bone and muscles. Laterally, right lateral expansion of about 3 to 5 millimeters off the IVC. Left lateral expansion of 1 to 2 centimeters typically extending the medial border of the left psoas muscle. For the common iliac nodes, and I'll show some pictures of these, and I know I'm going through this relatively fast, but I want to get some of the wording done. So for the common iliac nodal CTV, the CTV starts immediately beneath the PA nodal CTV at the aortic bifurcation. There's a 7 millimeter uniform expansion off the right and left common iliac vessels, excluding bone and muscle. At the midpoint of the common iliac vessels, the CTV margin should increase to 1 centimeter anterior to the vessels, abutting the psoas muscle laterally. And this was really a very good collaboration, because our surgeon who's from Memorial, who does a fair amount of sentinel nodes, really did point that sometimes in that area this is not, it's a little bit more anterior than we would think. And the common iliac nodal CTV extends inferiorly until the bifurcation of the common iliac artery. And this is an example of some of the contours, the periodic and common iliac nodal CTVs. Again, the superior portion of the periodic nodal CTV begins at or 1 to 1.5 centimeters above the left renal vessels. Again, at was felt adequate for cervical and 1 to 1.5 for endometrial. Again, as long as there's not high periodic nodal tissue or nodal disease. The contour extends laterally to the left psoas muscle. This is an example of the distended IVC. You can see the white arrow pointing to it, and I'll show some more examples of that. And then you see some of the upper contours and some of the lower periodic contours that we noted. And again, the black line shows that area where we think you should go at least 1 centimeter anterior lateral to the common iliac nodes along the mid-common iliac chain. Presacral nodal volume, we had a fair amount of debate about when you should treat this. The presacral node should definitely be included for all postoperative cervical cancer patients, and probably for all patients with endometrial cancer who have cervical stromal involvement, and then should be considered in cases with other high-risk factors for nodal involvement. Some of the current trials that are being published, PORTEC trial wanted, PORTEC 3 encouraged, actually I think mandated presacral nodal coverage, GOG 249 and 248 left it up to the discretion of the investigator, even if there was not cervical involvement. The superior extent is at the bifurcation of the internal and external iliac vessels is a relatively fixed strip of tissue measuring 1 to 1.5 centimeters wide in a perpendicular plane to the face of the sacral bodies. And the inferior extent is the first CT image where the piriform muscle becomes apparent. This is just an example of the presacral space. These are all the contouring overlays, and then the 95% confidence interval for the 13 different contours we got. Although they look relatively similar, there was one contour that went significantly lower, as you can see down here. Most of them were pretty consistent amongst the quote-unquote gynae experts. This is just an example. I think this is a pearl that people should take home from. This is an example of an IVC when there's contrast and when there's not. So again, the way I do my post-op endometrial and cervical patients, and really almost all my patients, is I usually do a non-contrast scan for which I will be contouring on, followed by a contrast scan so that I can get better definition of the vessels, but I always contour on the non-contrast scan, both for these kind of reasons and also for heterogeneity. The external iliac nodal CTV, the CTV begins superiorly at the bifurcation of the common iliac vessels, and again is a 7 millimeter uniform expansion off the external iliac vessels, excluding adjacent bone and muscle, but can extend up to 10 millimeters anteriorly. Again, some of that is from our surgical colleagues. And this continues inferiorly until the external iliac vessels course laterally as they leave the pelvis, becoming the inguinal femoral vessels. And the inferior extent can be delineated where the deep circumflex artery branches off the external iliac artery. And then the internal iliac nodal CTV begins superiorly again at the bifurcation of the common iliacs, excluding bone and muscle. And this volume courses distally until the vessels turn laterally before leaving the pelvis. The obturator nodal CTV is a strip of space about 15 to 18 millimeters in diameter, medial to the obturator internus muscle, situated between the external and internal iliac vessels, not extending into bone, muscle, or bladder. And this continues inferiorly until the obturator vessels leave the pelvis through the obturator foramen. In consideration for an obturator nodal internal target volume, which we'll talk about, or a larger PTV for this region, should be considered to account for changes in bladder filling. And again, these are some examples. I know this isn't easy to see on a slide. Again, these are online. These are examples of external, internal, presacral. The white arrows in the B figure are where we stop the presacral area. The blue arrow in C is where you see the circumflex artery, which is actually relatively easy to see. And then you see the obturator lymph node area going down to where the obturator vessels leave the pelvis. The vaginal CTV should include the proximal 3.5 to 4 centimeters of vaginal canal. Again, there's some exceptions to these rules, and these are just guidelines. They're not meant to, there's individual changes that need to be made for each patient. And any paravaginal or retracted parametrial tissue that can be visualized in the planning CT. For routine cases, if you can see it, the urethra can be excluded from the CTV. And usually most of us put a flexible vaginal marker at the time of CT simulation to better visualize the vaginal cuff. Surgical clips may also be helpful. Just make sure whatever marker you put in does not distend the vagina. The CTV should extend posterior to the anterior rectal wall and should include the anterior 1/3 of the mesorectum. We talked a lot about how to work on consistency of the rectal distension. I'll talk a little bit about that later. The anterior border is the posterior border of the bladder wall, and the lateral extent is the medial border of the obturator nodal volume or the urogenital diaphragm more inferiorly. And these are just some examples of the vaginal CTV, both higher, a coronal section where you have some dog ears with retracted parametrium, and then lower. Use of an internal target volume. Things move a lot, so I think that that's something that we've learned in the pelvis. Obviously, there's not a lot of movement for respiration, but there's a lot of movement both rectal and bladder filling. So if you don't use an internal target volume, which means trying to CT the patient with a full and empty bladder, really you probably need a fairly large PTV, especially in the vaginal cuff area. And this is an example of one of my patients who happened to be on RTOG 0418. These scans were taken minutes apart with a full and empty bladder, and you can see there is a significant movement in the vaginal cuff, which is probably one of our main targets for postoperative treatment. Again, minutes apart, showing a significant movement with significant more rectal distension with an empty bladder. And again, this is from the publication. This is showing an internal target volume, accounting for bladder motion as much as you can. The vaginal cuff can move a couple centimeters, so if you're not accounting for that, the PTV should be relatively large. Rectal distension, I touched a little bit on that in the sense that we couldn't come to a consensus on whether or not we should do things like rectal enemas on a daily basis. It's difficult to control rectal distension. So if it's distended on your CT, consider including the anterior 1/3 to 1/2 to account for rectal variation. IGRT, I'm just going to touch on it briefly. I would consider IGRT with cone beam CT. It may or may not allow tighter margins. I've certainly used it consistently, and I've noted not infrequently having to replan either because of overdistension in the bladder, rectum, or other significant challenges that I've seen during treatment. So thank you for these 20 minutes. So I hope I kind of gave you some background on why we do contouring atlas and show some pearls. But again, as we know, accurate target definition is critically important when it comes to treating anything in radiation, but especially when you're trying to do something tight with postoperative treatment. We certainly need further research on paradigm recurrence. This is based on what I told you, atlases, embryology. We need to analyze, and I'm hopefully in the process of doing that soon, the big randomized trials that use this atlas and see if there are areas that were either we included that we didn't need to, which will be hard to tell because hopefully they wouldn't have recurred there, but mostly if there's areas we should have included. I think the one pearl really is there's really significant internal motion that needs to be accounted for treatment. So if you look at how I actually plan, my ITV is pretty generous because I've lived through the 3D where we treat the whole pelvis, although we had much higher complications, people did okay. So I think if the other thing is if you're doing this, be more generous than tight. I think most people can tolerate 45 to 50, great, but it really does help that middle pelvis with all the small bowel post-treatment. And I think IGRT should be encouraged. I typically do it. I think it helps, especially to know when your PTV margins need to change because of a changing in rectal or bladder involvement filling that you didn't account for. Again, thank you very much. I really appreciate the time, and I'm happy to take any questions.
Thank you very much, Professor Small, for this elegant, illustrative, and very good presentations for all of us, the young colleagues as well as the old one like myself.
We should say not so young, not old, not so young.
Any questions? I have one question.
Yes.
Regarding the motion treatment, is there any maneuver to do except the IGR, the cone beam CT, using the LINAC, not the MR LINAC or the other new techniques of radiation therapy?
Well, specifically how I treat is I'll take the patient and immobilize the patient in the CT scanner, put a very non-distending Q-tip-like substance in the vagina and an introidal marker, and do the initial sim with a full bladder, and then I set my isocenter. Patient gets up, drinks barium, gets an IV for their IV contrast, and then right before the simulation empties their bladder, I replace the vaginal marker and get an empty bladder scan. Then I do a CTV on both those volumes, merge them for an ITV, and I typically add 7 millimeters for a PTV. That's what I do. And if I have any question on what the volume is, I add it. And then I'm typically doing cone beam CTs every day to review the bladder and rectal distension. I'm also part of something called the International Commission on Radiation Protection, ICRP. We're in the process of doing a task force on the radiation protection of daily imaging. We should probably take that into account. But I do think that IGRT, actually, to my role, really does seem to help. So when I look at the films on a daily basis, I turn on my ITV and PTV, and the imaging's got good enough that I really can see, I think that we're still in the target. And I would say probably 10% of my patients, their bladder, mostly it's over distension. Their bladder's fuller than it was in the CT, and it's pushed the vaginal cuff farther away, and I've had to replan for that. And I use the cone beam CT fused with the initial planning CT and tweak the ITV. It's relatively quick. So yeah, I typically don't use an MR. We have an MR Linux. I haven't been using it for this because it's at another institution. So I've been using just cone beam CT.
Thank you. There are another questions? Yes, Dr. Shri. Yes.
Did you treat the lower para-aortic if involved only or if it's high risk for involvement?
You know, that's a great question. I grew up with the old R2G 7901 cervix where we treated extended field a lot. I typically treat extended field more often than others. We did not in this consensus with prophylactic extended field. In the consensus, we did not try to tackle that question because it's relatively controversial. But if there is nodal disease in the pelvis and the parotix have not been dissected in either endometrial or cervical, I'll typically treat. But that's me. I think some people will treat only if there's commons or higher nodes involved. And if there's a periodic dissection, either sentinel or dissected, I typically don't prophylactically treat.
Any more questions?
Thank you.
Thank you very much.
Thank you so much for having me.
Thank you. Thank you.